Most people assume that once a surgeon says, "You need this operation," the decision is basically over. The white coat carries authority. The hospital feels reassuring. The consent form looks official. And when fear is in the room, most people do what they think they're supposed to do. They say, "Yes, I understand why, but I want to tell you something that too many older adults learn too late." For seniors, the real danger is not always the diagnosis that led to surgery. Sometimes, the greater danger is what the surgery puts the body through. I've seen people go in expecting relief and come out facing a recovery they were never truly prepared for. I've seen families told an operation was successful, only to spend the next 3 months dealing with confusion, weakness, infections, rehab, and a quality of life that never quite returned to where it was before. That is the part almost nobody explains clearly enough. The older the body gets, the less margin for error it has. A younger body can often absorb surgical stress and fight its way back. An older body may survive the operation itself and still struggle deeply with everything that comes after it. My name is Dr. William Lee, and today I want to walk you through 5 surgeries that seniors should never agree to casually, automatically, or without asking much harder questions first. And before we get into them, let me say one quick thing, because it matters. If you care about staying strong, independent, mentally sharp, and in control of your health as you get older, then stay with me all the way to the end of this video, because I'm also going to give you the exact questions every senior should ask before saying yes to any major procedure. And if this kind of information helps you, subscribe, like the video, and leave a comment, because it helps this message reach more people who may be standing on the edge of a medical decision right now. Now let me ask you something. If you took a brand new smartphone and one that had been dropped, overheated, and running low on battery for years, would you expect both to handle the same heavy workload the same way? Of course not. And yet that is often how surgery is still presented to older adults. Same procedure, same language, same confidence. Same promise of recovery, but not the same body. Aging changes everything about how the body responds under pressure. The heart has less reserve. The lungs clear anesthesia more slowly. The kidneys may not process drugs as efficiently. The immune system does not respond with the same speed it once did. Muscle mass is lower, balance is more fragile, appetite may be weaker, and the brain itself can become much more vulnerable to the shock of hospitalization, pain medication, sleep disruption, and general anesthesia. That's why 2 people can have the exact same operation and experience 2 completely different outcomes. And this brings us to one of the most important words in medicine for older adults: frailty. Frailty is not just getting older, it is a measurable decline in strength, resilience, recovery capacity, and physiologic reserve. And once frailty enters the picture, the question changes. The question is no longer, can this person get through surgery? The real question becomes, can this person get through recovery with their body, brain, and independence intact? That is a very different question, and it's the one too many families never think to ask. So let me talk about 5 surgeries seniors should never agree to without slowing down and looking at the full picture. Number 1, open heart surgery in a frail senior. When people hear that their heart has a serious blockage or valve problem, the reaction is immediate. Fix it, do whatever it takes, do it now. And sometimes that is absolutely the right call. But for a frail, older adult, traditional open heart surgery can be far more punishing than people realize. This is not a small event. The chest is opened. The body undergoes massive physiologic stress. Inflammation surges. The heart and lungs may need mechanical support during the procedure. Recovery can be long, painful, and unpredictable. In a healthy, robust 62-year-old, the body may tolerate that stress surprisingly well. In a 79-year-old with diabetes, kidney impairment, mild memory issues, lung disease, or reduced mobility, that same operation can become a completely different risk category. What people often are not told clearly enough is that the problem is not just whether the surgery works technically, the problem is what it costs the body to get there. After major cardiac surgery, Older adults are at higher risk for delirium, pneumonia, prolonged weakness, kidney complications, stroke, loss of independence, and long hospital stays that can permanently change the course of their life. And sometimes, the operation solves one issue while creating three new ones. Now listen carefully because this is important. This does not mean a senior should never have heart surgery. It means no senior should agree to it without asking one essential question. Is there a less invasive option available for someone with my age, frailty level, and medical profile? Because today, in many cases, there are alternatives. Catheter-based procedures, minimally invasive valve interventions, stents in selected cases, and optimized medical therapy can sometimes offer meaningful benefit with less trauma to the body. The goal is not to be dramatic. The goal is to match the treatment to the body that has to survive it. Number 2. Complex spinal fusion for chronic back pain. This one is offered far more often than many people realize. A senior has back pain, maybe leg pain, maybe spinal stenosis, maybe degenerative disc disease. They've been uncomfortable for years, exhausted, frustrated, and finally somebody says, "We can fix this with surgery." That sentence is powerful. When pain has worn a person down, the word fix sounds like hope. But complex spinal fusion in older adults is one of the surgeries that deserves extreme caution. Why? Because it is not a simple cleanup. It can involve multiple levels of the spine, screws, rods, bone grafting, long anesthesia time, blood loss, extended recovery, and permanent changes to the mechanics of the back. And here is the hard truth. For many seniors with chronic degenerative back pain, the long-term pain relief after major spinal fusion is nowhere near as predictable as people are led to believe. Some improve only modestly, and some go through an enormous operation only to find that the pain is different, not gone. Meanwhile, the complication risks are very real. Blood clots, infections, hardware failure, worsened mobility, prolonged rehab, falls during recovery, and something people rarely discuss enough. Once one part of the spine is locked down, the segments above and below it may begin taking extra strain. In other words, one mechanical problem can become another. Now, to be fair, there are situations where spinal surgery is absolutely necessary. If there is severe nerve compression, progressive weakness, bowel or bladder dysfunction, spinal instability, or a true neurologic emergency, that is a different conversation entirely. But elective multi-level fusion for chronic pain in an older adult should never be treated like an obvious decision. If a senior is being told surgery is the only answer for long-standing back pain, they should pause and ask, what happens if I choose physical therapy, targeted injections, pain management, strength training, balance work, weight reduction, or a less aggressive procedure instead? Because sometimes the best result is not the most aggressive intervention. Sometimes the best result is the one that preserves function without pushing the body into a recovery it cannot handle. Number 3, massive cancer surgery in a senior whose body is already weakened. This is one of the hardest conversations in all of medicine. Cancer terrifies people, and understandably so. The instinct is immediate. Get it out, remove it, act fast. Emotionally, that makes perfect sense. But medicine is not just about removing disease. Medicine is supposed to be about helping a person live better and longer, and in some older adults, especially those who are already frail, major cancer surgery can become a treatment that overwhelms the patient more than the cancer would in the short term. Think about operations like a Whipple procedure for pancreatic cancer, major colon surgery in a very weak patient, radical bladder surgery, or extensive abdominal cancer resections. These are among the most physically demanding operations a human body can go through. Long operating times, major physiologic stress, fluid shifts, risk of infection, risk of leaks, risk of ICU stays, risk of being unable to eat normally, risk of never fully regaining strength. And here is the question families must be willing to face honestly. Are we treating the cancer, or are we putting the patient through something their body no longer has the reserve to recover from? That is not giving up. That is mature, brave, medically responsible thinking. In older adults, especially those with heart disease, low muscle mass, cognitive decline, poor mobility, or weight loss, the discussion should never be only about whether the tumor can be removed. It should also be about what the likely life on the other side of surgery actually looks like. Will this operation realistically provide more good months or years? Or will it create a cascade of complications, rehabilitation, repeat hospitalizations, and suffering that steals the very time it was supposed to preserve? These are difficult questions, but they are necessary questions. Sometimes surgery is still the right choice, but sometimes radiation, immunotherapy, targeted therapy, symptom management, or a less aggressive plan is more aligned with the patient's real goals. A senior should never agree to major cancer surgery without asking, if we do this, what is the best realistic outcome for someone in my exact condition? And if we do not do this, what other paths still exist? That conversation changes everything. Number 4, elective joint replacement in a senior with multiple serious health problems. Now I want to be careful here, because hip and knee replacements can be life-changing in the right patient. Done at the right time, in the right body, for the right reason, they can restore mobility, reduce pain, and dramatically improve quality of life. I have seen that happen. But elective is the key word. Elective means there is time. Time to prepare. Time to optimize. Time to get stronger. Time to ask whether now is truly the safest moment. Too many people hear that a hip or knee replacement is common and assume that means it is low risk for everyone. It is not. Not for the senior with heart failure, not for the senior with uncontrolled diabetes, not for the senior with kidney disease, obesity, sleep apnea, poor circulation, lung disease, or a history of blood clots. Not for the senior who is already weak, sedentary, and struggling to bounce back from minor illnesses. In those patients, even a planned joint replacement can trigger a serious downhill course. Clots can form, infections can occur, pneumonia can develop, confusion after anesthesia can set in, a hospital stay can turn into rehab, then limited mobility, then deconditioning, then a loss of confidence that is hard to recover from. And there is another issue people rarely think enough about. If a person is already very deconditioned before surgery, what exactly is going to carry them through rehabilitation after surgery? Because the procedure is only one part of the journey. The recovery is where the real outcome gets decided. That is why seniors should never casually agree to joint replacement without first asking, have I done everything possible to improve my odds before surgery? That means improving blood sugar, reviewing medications, evaluating the heart and lungs, building leg strength, increasing protein intake, losing even a modest amount of excess weight when appropriate, addressing anemia, improving sleep, practicing walking, planning support at home. This is called prehabilitation, and it can make a major difference. A joint replacement should not feel like ordering a part for a machine. It should feel like preparing a whole body for a major event. Number 5. Emergency abdominal surgery when warning signs were ignored for too long. This one is different from the others, because unlike elective procedures, emergency surgery often arrives without warning. A bowel obstruction, a perforated ulcer, a ruptured appendix, a strangulated hernia, internal bleeding, a dead segment of intestine. These are terrifying situations, and once they happen, the decisions become fast, emotional, and extremely difficult. Why does this belong on the list? Because by the time a frail senior reaches emergency abdominal surgery, the body is often fighting on too many fronts at once. Pain, dehydration, infection, inflammation, low blood pressure, metabolic stress, organ strain, and older bodies do not absorb sudden physiologic chaos the way younger ones do. This is where mortality rises sharply. This is where recovery becomes uncertain. This is where families find themselves standing in hallways hearing words like septic shock, respiratory failure, kidney injury, ICU, ventilator, and guarded prognosis. That is why the most important lesson here is not simply about the surgery. It is about preventing the emergency whenever possible. Seniors should never ignore persistent abdominal pain, vomiting, severe constipation, black stools, bloating that does not resolve, unexplained weight loss, or a dramatic change in bowel habits. Too many people hope it will pass. Too many wait through the weekend. Too many try to tough it out. Too many arrive only when the condition has become dangerous. And there is one more truth here that families need to hear. Before an emergency ever happens, seniors should have honest conversations with loved ones about what they would want if a life-threatening operation became the only option. Not in the emergency room, not at midnight, not after a crisis has already shattered everyone's ability to think clearly. Before. What level of recovery would be acceptable? What quality of life matters most? What trade-offs are worth it? What would they want if survival meant a prolonged ICU stay and a life they might not have chosen? These conversations are not pessimistic, they are loving. They spare families from making impossible decisions in a fog of fear. Now we've covered the 5 surgeries, but knowledge without action just becomes stress, and I do not want that for you. So let me give you the 4 questions every senior should ask before agreeing to any major procedure. Question 1. What happens if I do nothing for now? This question is incredibly powerful, because sometimes the answer is, this is truly urgent and delay is dangerous. But sometimes the answer is, nothing catastrophic is likely to happen in the next few weeks or months. And if that is the answer, then you have something precious. Time. Time to think. Time to prepare. Time to get stronger. Time to gather another opinion. Time to choose instead of react. Question 2. Is there a less invasive alternative? Medicine has changed dramatically. Catheter-based procedures, laparoscopic techniques, robotic surgery, targeted therapies, regional anesthesia, interventional radiology, conservative management. Options exist today that did not exist years ago. If nobody has discussed alternatives, that does not always mean there are none. It may simply mean the conversation has not been thorough enough yet. Question 3. What does recovery actually look like for someone my age, with my health conditions? Not the average patient, you. Your medications, your heart, your lungs, your kidneys, your memory, your strength, your living situation, your fall risk, your support system. This question matters because many seniors are given excellent explanations of the procedure and almost no realistic explanation of the recovery. And for older adults, recovery is the story. Question 4. If this were your parent, in this exact condition, what would you advise? This is one of the most human questions you can ask a doctor. And a thoughtful doctor will take it seriously, not because they can decide for you, but because it forces the conversation out of statistics and into values, trade-offs, and real-life judgment. Now I want to talk about something that can change the outcome of surgery more than people realize. Preparation. Most people spend more time preparing for a vacation than they do preparing their body for a major operation. That has to change. If a surgery truly is the right decision, then the weeks beforehand matter enormously. Walk every day if you are able. Build leg strength. Increase protein if your doctor says it is appropriate. Review every medication and supplement. Stop smoking. Address poor sleep. Treat anemia. Control blood sugar. Improve hydration. Practice breathing exercises. Arrange help at home. Clear tripping hazards. Fill prescriptions in advance. Set up the bedroom so the first few days are safer and easier. These are not small details. These are recovery tools. And then there is the brain. Older adults are especially vulnerable to confusion and cognitive decline after surgery. So ask about anesthesia options. Ask whether regional anesthesia is possible. Ask how delirium risk is being reduced. Make sure glasses and hearing aids are available again as soon as possible after surgery. Make sure pain is managed, but not blindly over-medicated. Protect sleep. Encourage early mobility. These things matter more than most people know. And here is one more rule that I want every senior to remember. Do not go to a major surgical consultation alone. Bring a spouse. Bring an adult child. Bring a friend. Bring someone calm enough to listen when you may not be able to. Because the moment people hear words like tumor, blockage, operation, ICU, or risk, the mind narrows. Fear takes over. Memory drops. Questions disappear. Details get lost. That is human. A second set of ears can catch what you miss, write things down, ask the hard question you forgot, and help you think clearly afterward. That single choice can prevent a terrible misunderstanding. And now I want to leave you with something hopeful. Because this is not a message of fear, it is a message of smarter medicine. I remember a patient in his 70s who had been told by more than one specialist that a major operation was the logical next step. He was not refusing care, he simply wanted to understand what that care would cost him, not financially. Physically, he said something I have never forgotten. He said, "I'm not just trying to stay alive, I'm trying to stay myself." That is the heart of this entire conversation, because survival is not the only outcome that matters. Function matters, clarity matters, mobility matters, dignity matters. Time that feels like life matters. So let's bring this all together. The 5 surgeries seniors should never agree to, casually, are these: open heart surgery in a frail body without first exploring less invasive options. Complex spinal fusion for chronic pain without exhausting better matched alternatives. Major cancer surgery in a weakened senior without a brutally honest discussion of likely benefit versus likely burden. Elective joint replacement in someone medically unstable or physically unprepared. And emergency abdominal surgery that becomes necessary because early warning signs were missed and important family conversations never happened. This does not mean all surgery is bad, far from it. Surgery saves lives every day. The point is this: a surgical recommendation is not the end of the conversation, it is the beginning of one. You have the right to ask harder questions. You have the right to ask for time. You have the right to ask about alternatives. You have the right to ask what recovery will really look like. You have the right to ask for a second opinion, and you have the right to make a decision based not only on what can be done, but on what truly serves your life. That is not being difficult. That is being wise. So before I close, I want to ask you one question. If a doctor recommended major surgery tomorrow, what is the very first question you would ask before saying yes? Leave it in the comments. And if this message could help a parent, spouse, sibling, or friend think more clearly about a serious medical decision, share this video with them. It may be one of the most important conversations you help start. Take care of yourself. Stay informed. Stay calm. Keep asking better questions. And never forget this: the surgeon may hold the scalpel, but you still hold the choice. And one final note. Everything I've shared today is general educational information and should never replace individualized medical advice. Every person's health, risks, goals, and treatment options are different. Before making any decision about surgery, speak directly with your own physician and specialist so you can make the best decision for your specific situation.